Hypertension or high blood pressure is the nation's most common chronic health problem, affecting about 66 million people. But can you identify which ones have hypertension? It's not as easy as you may think. Many patients with hypertension have no symptoms. Yet because the disease affects the blood supply to all the major organs, these patients may be at risk of organ damage and death. That's why hypertension is often called the silent killer. This program will help you identify patients with hypertension and those at risk. By linking the pathophysiology of hypertension with its acute and chronic complications, it also will help you effectively treat patients with hypertension before complications can occur. This patient saw his primary care physician because he had a dull headache, blurred vision, and right-sided weakness that resolved. At the time, his blood pressure was high, 220/110 millimeters of mercury. Now he's being admitted to your unit for evaluation because his symptoms suggest an acute complication of hypertension. But do you know what causes high blood pressure and how the body normally controls it? Hypertension is the persistent elevation of systemic arterial blood pressure. It may be primary or secondary. Primary or essential hypertension has no known cause, although it's linked to several risk factors. Secondary hypertension has an identifiable cause, such as a disease or drug. Several factors increase the risk of developing primary hypertension. Some risk factors can't be modified, but others can, with lifestyle changes. Unmodifiable risk factors include a family history of hypertension, African American heritage, and advancing age. Modifiable risk factors include obesity, uncontrolled diabetes mellitus, sedentary lifestyle, high sodium diet, low potassium diet, excess alcohol intake, chronic stress, and smoking. To understand how modifiable and unmodifiable factors increase this patient's risk for hypertension, you must first understand the mechanisms that normally control blood pressure. Blood pressure is the force exerted by blood against the arterial walls. It helps propel blood through a vast network of vessels to reach the body's organs. During ventricular contraction or systole, the peripheral arteries expand as blood is ejected from the aorta. When this occurs, the pressure in the arteries is called the systolic blood pressure. During ventricular relaxation, or diastole, the peripheral arteries constrict slightly as the ventricles fill with blood. When this happens, the pressure in the arteries is called the diastolic blood pressure. Two major forces work to control blood pressure. They are peripheral vascular resistance, which is the artery's resistance to blood flow, and cardiac output, which is the amount of blood ejected from the heart in 1 minute. These forces are affected by various factors. For example, peripheral vascular resistance is affected by vessel diameter and elasticity, and blood viscosity. Cardiac output is affected by blood volume, ventricular contractility, and heart rate. Changes in these factors can alter peripheral vascular resistance or cardiac output, which can affect blood pressure. For example, as vessel diameter decreases, peripheral resistance to blood flow increases. The body controls vessel diameter by constricting and dilating the vessels. Vasoconstriction can occur when stress causes the adrenal medulla to release the catecholamines, epinephrine and norepinephrine, which stimulate the sympathetic nervous system. When released in large amounts, catecholamines stimulate alpha-1 receptors in the peripheral arteries. This makes the vessels constrict, quickly raising the blood pressure. When catecholamines are released in smaller amounts or when they act on beta-2 receptors in blood vessels, the arteries dilate, which lowers the blood pressure. Vessel diameter also can increase when chemicals in the blood such as carbon dioxide, potassium, nitric oxide, and hydrogen cause the arteries to dilate. Decreased vessel elasticity occurs when atherosclerosis stiffens and blocks the arteries. Because they no longer stretch easily, the arteries can't expand to accommodate increased blood volume. And this elevates the blood pressure. Increased blood viscosity also causes the blood pressure to rise. This occurs when the hematocrit is abnormally high, as in polycythemia vera and other disorders. Increased blood volume can occur when the catecholamines stimulate beta-1 receptors in the kidneys. This activates the renin-angiotensin-aldosterone system, which raises the blood pressure slowly. In this system, the release of renin causes an enzyme in the lungs to convert angiotensin I to angiotensin II. Then angiotensin II triggers the release of aldosterone. In the kidneys, angiotensin II and aldosterone prevent sodium and water from entering the loop of Henle, which increases sodium and water reabsorption into the bloodstream. This raises blood volume and the blood pressure. Catecholamine release also affects ventricular contractility. By stimulating beta-1 receptors, catecholamines increase contractility, which raises cardiac output and blood pressure. This stimulation also increases the heart rate, which boosts the cardiac output and blood pressure in yet another way. This patient has several unmodifiable risk factors for primary hypertension. First, he has close relatives with hypertension. This family history greatly increases his chance of developing the disorder himself. Second, he is African American, and this heritage is associated with higher blood pressure readings and a higher incidence of hypertension. These two factors may increase the risk for hypertension because of specific genes or shared environmental factors, such as lifestyle and diet. Also, an African American heritage is linked to sodium sensitivity. In this condition, the kidneys don't excrete sodium effectively. As a result, the blood retains more sodium and water, increasing the blood volume and blood pressure. In addition, this patient is over age 50. With advancing age, the arterial walls lose their elasticity. When this occurs, the arteries narrow and can't expand fully during systole, increasing the peripheral vascular resistance. This leads to isolated systolic hypertension, in which the systolic pressure is increased, but the diastolic pressure is not. Fortunately, this patient can reduce his risk of developing hypertension, or the severity of it, by changing his modifiable risk factors. For example, he can control his weight and blood glucose level. Obesity and uncontrolled diabetes mellitus may increase the risk of hypertension because they are associated with insulin resistance. In this condition, glucose can't readily enter the cells because their insulin receptors are too few or dysfunctional. In response, the body produces more circulating insulin. The rise in insulin may increase catecholamine secretion, leading to vasoconstriction, sodium and water retention, and vascular hypertrophy. Eventually, peripheral vascular resistance and the blood volume climb, raising the blood pressure. Another way this patient can reduce his risk is by engaging in regular physical exercise. A sedentary lifestyle may promote hypertension in two ways. First, it can lead to obesity. And second, it doesn't offer the protection of regular physical exercise, which raises the amount of high-density lipoproteins, or HDLs, that remove cholesterol from the blood. Without exercise, the cholesterol levels stay high and may impair vasodilation by blocking nitric oxide. Your patient could reduce his risk by changing his diet, because a high-sodium diet is associated with hypertension. In some patients, the kidney's ability to excrete sodium is impaired. If such a patient eats a high-sodium diet, his body retains sodium and water. This increases the blood volume, which ultimately raises the blood pressure. A low-potassium diet tends to worsen sodium-induced hypertension. Your patient also can reduce his risk of hypertension by avoiding excess alcohol intake. Having more than 3 alcoholic drinks per day may raise the systolic blood pressure by stimulating renin production, which causes vasoconstriction and sodium and water retention, inducing insulin resistance, as in obesity and diabetes, and damaging smooth muscle cell membranes. This lets calcium enter the cells, preventing smooth muscle relaxation and causing vasoconstriction. By reducing stress, your patient can also decrease his risk of hypertension. During stressful episodes, the adrenal medulla secretes catecholamines to raise the blood pressure in a fight-or-flight response. However, with prolonged stress, the catecholamine release becomes sustained, and blood pressure remains elevated. In addition, baroreceptors in the aorta, heart, and lungs become desensitized. When overstimulated, these pressure sensors lose their ability to detect high blood pressure and signal the nervous system to correct it. So blood pressure remains high even when the patient isn't feeling stressed. Finally, your patient can decrease his risk by not smoking. Cigarette smoking may raise the blood pressure by providing nicotine, which stimulates the sympathetic nervous system. In a patient with secondary hypertension, the cause is a disease or drug. For example, this patient has secondary hypertension caused by renal artery stenosis. The narrowed renal artery slows blood flow to the kidneys, which triggers the release of renin. This activates the renin-angiotensin-aldosterone system, which produces the end products angiotensin II and aldosterone. Angiotensin II causes vasoconstriction. Aldosterone causes sodium and water reabsorption, which increases blood volume. Together, they raise the blood pressure. Other causes of secondary hypertension include renal parenchymal diseases, endocrine disorders, catecholamine-secreting tumors, pregnancy, coarctation of the aorta, and drugs such as oral contraceptives or cyclosporin. Patients with hypertension usually don't develop symptoms until chronically high blood pressure leads to complications such as vascular changes or organ damage. Vascular changes affect the arteries, which supply oxygenated blood to the organs. Normally, arteries have 4 intact layers: the outer tunica adventitia, the elastic membrane, the muscular tunica media, and the inner tunica intima. In hypertension, prolonged vasoconstriction and increased pressure cause the tunica media's smooth muscle cells to enlarge and multiply. This permanently narrows the artery. Hypertension also thickens and causes breaks in the tunica intima's endothelial layer, allowing lipids, plasma proteins, and calcium to enter. All of these changes permanently damage the arterial wall and promote atherosclerosis. Certain organs are prone to damage from high blood pressure. These target organs include the brain, eyes, heart, peripheral vessels, and kidneys. When you need to assess a patient with hypertension, remember to check all the body systems, especially the target organs, for complications. Begin by measuring the patient's blood pressure, keeping in mind that a diagnosis of hypertension usually is based on 2 or more seated blood pressure readings in at least 2 sequential office visits. To classify your patient's blood pressure, consider the national standards for blood pressure. A normal blood pressure produces a systolic reading of less than 120 millimeters of mercury and a diastolic reading of less than 80 millimeters of mercury. Prehypertension is characterized by a systolic reading of 120 to 139 millimeters of mercury and a diastolic reading of 80 to 89 millimeters of mercury. Stage 1 hypertension is characterized by a systolic reading of 140 to 159 millimeters of mercury and a diastolic reading of 90 to 99 millimeters of mercury. And Stage 2 hypertension is characterized by a systolic reading at or greater than 160 millimeters of mercury and a diastolic reading at or greater than 100 millimeters of mercury. Be alert for hypertension that progresses rapidly and produces a systolic pressure of 180 millimeters of mercury or more, or a diastolic pressure of 140 millimeters of mercury or more. This signals hypertensive crisis, a life-threatening complication. Hypertensive crisis damages target organs and causes emergencies such as hypertensive encephalopathy and cerebrovascular accident, or CVA. When examining the patient's nervous system, ask about headaches, which may be the only symptoms of hypertension. Hypertension usually produces throbbing occipital or frontal headaches that are severe in the morning but diminish as the day progresses. These headaches typically result from vasodilation, which stimulates certain nerves to transmit pain signals. Also, carefully assess the patient's level of consciousness, which may be decreased. A decreased level of consciousness primarily results from cerebral edema. Normally, cerebral arterioles constrict to protect the delicate brain tissue from high arterial pressure. However, as the arterial pressure climbs, it overcomes the arterioles, causing them to dilate. This results in high capillary hydrostatic pressure and increased capillary permeability. Eventually, fluid leaks from the capillaries into the interstitial space, causing cerebral edema. If untreated, edema can progress to cerebral ischemia or a CVA. If you suspect cerebral ischemia, assess for weakness in the patient's arms or legs, changes in her speech or behavior, and difficulty swallowing. When assessing your patient's eyes, ask about symptoms such as blurring or loss of vision. Then, using an ophthalmoscope, assess the retina. Here, vascular changes are easy to see and reflect the severity of the hypertension. Signs of irreversible retinal damage begin in Stage 2 hypertension, when the retinal arteries narrow and thicken to protect the delicate retinal structures from high pressure. This causes AV nicking, in which retinal veins appear nicked or cut where they cross retinal arteries. As the high blood pressure overcomes the arteries, bloody fluid leaks into the retina, forming retinal hemorrhages, and soft white exudates known as cotton wool patches. Then the optic disc swells, resulting in papilledema. Continue by asking the patient about epistaxis, or nosebleeds. Epistaxis occurs when high blood pressure ruptures the small, fragile blood vessels in the back of the nose. When assessing the cardiovascular system, begin by palpating the precordium. As you palpate, note the apical impulse. Normally it's short and gentle. In hypertension, it's longer and much more forceful. That's because the left ventricle must increase its force of contraction to overcome the increased blood pressure in the aorta. Over time, this thickens the myocardial muscle fibers, leading to left ventricular hypertrophy. Next, auscultate the patient's heart sounds, evaluating the heart rate and rhythm and listening for extra heart sounds and murmurs. Assess for signs and symptoms of myocardial ischemia, such as chest pain, and peripheral ischemia, such as pain or claudication in the arms and legs. These symptoms occur because arteries damaged by high pressure commonly develop atherosclerosis. Next, palpate the peripheral pulses. Like pain, a weak pulse can result from atherosclerosis. Also, auscultate the aorta and carotid, renal, and femoral arteries to detect bruits. These murmur-like sounds are caused by turbulent blood flow in arteries that are narrowed by atherosclerosis. As you assess the patient's respiratory system, ask about dyspnea and auscultate the lungs for crackles. Both findings can occur when chronic uncontrolled hypertension leads to left ventricular hypertrophy and heart failure. As blood backs up into the left atrium and pulmonary vessels, high pulmonary capillary pressure causes fluid to leak into the interstitial space. Eventually, interstitial hydrostatic pressure forces interstitial fluid into the alveoli. With each inhalation, air enters the fluid-filled alveoli, producing crackles and dyspnea. During the assessment, check the appearance of the patient's urine. It may look dark and cloudy. That's because, as renal damage progresses, increased arterial permeability lets protein and red blood cells leak into the urine, changing its appearance. Finally, check for peripheral edema, which results from fluid movement into the interstitial space. To detect complications of hypertension or to identify its cause, prepare your patient for diagnostic tests as needed. When the tests are completed, review their results. Your patient's urinalysis may detect red blood cells, protein, or hyaline casts, suggesting kidney damage. Or it may reveal glucose or ketones, indicating diabetes mellitus. If your patient undergoes 12-lead electrocardiography, it may show signs of myocardial ischemia or infarction, such as T-wave inversion, ST segment elevation, or Q-wave formation. Or it may display tall QRS complexes, indicating left ventricular hypertrophy. If he has a chest X-ray, it may reveal an enlarged heart or pulmonary congestion. Either may signal left-sided heart failure or pulmonary edema. Other tests may identify the cause of secondary hypertension. For example, elevated urine catecholamine and vanillomandelic acid levels may indicate pheochromocytoma. Renal angiography may show renal artery stenosis, or ultrasonography may detect coarctation of the aorta. After reviewing the test results and other findings with the patient's physician, work together to develop his treatment plan. To control hypertension, treatment usually depends on the degree of hypertension and the presence of certain concomitant disorders, such as diabetes mellitus or chronic renal failure. Pre-hypertension, a systolic pressure of 120 to 139 millimeters of mercury, and a diastolic pressure of 80 to 89 millimeters of mercury, calls for lifestyle changes, such as weight loss, regular exercise, sodium and alcohol restriction, and stress management. In addition, a diet high in fruits, vegetables, and low-fat dairy products with a reduced content of saturated fat and total fat, known as the DASH eating plan, should be implemented. Stage 1 hypertension, defined as a systolic pressure of 140 to 159 millimeters of mercury, and a diastolic pressure of 90 to 99 millimeters of mercury, calls for a thiazide-type diuretic for most patients. Those unable to take a thiazide-type diuretic require one of the following antihypertensive agents: an angiotensin-converting enzyme, or ACE inhibitor, an angiotensin II receptor blocker, or ARB, a beta-adrenergic blocker, or a calcium channel blocker, or a combination of these. Stage 2 hypertension, defined as a systolic pressure greater than 160 millimeters of mercury, or a diastolic pressure greater than 100 millimeters of mercury, requires a 2-drug combination, including a thiazide-type diuretic and one of the following: an ACE inhibitor, an ARB, a beta-adrenergic blocker, or a calcium channel blocker. High-risk patients may require more than 2 drugs to control blood pressure. These patients include those with diabetes or chronic kidney disease, a history of an MI or stroke, or a risk of coronary artery disease, and may require other types of antihypertensives, such as a renin inhibitor. Each hypertensive drug class works in a different way to control blood pressure. Diuretics act by increasing sodium and water excretion. This reduces the blood volume, which lowers the blood pressure. Beta-adrenergic blockers, such as propranolol, prevent the heart's beta-adrenergic receptors from being stimulated by catecholamines. This promotes vasodilation, lowering the blood pressure. Calcium channel blockers, such as diltiazem, work by preventing calcium ions from entering smooth muscle cells. This results in smooth muscle relaxation and vasodilation, ultimately reducing blood pressure. ACE inhibitors block an enzyme from converting angiotensin I to angiotensin II in the lungs. This prevents sodium and water retention and vasoconstriction, reducing the blood pressure. ARBs keep the angiotensin II from causing vasodilation, thereby lowering blood pressure. Renin inhibitors, such as aliskiren, act on the juxtaglomerular cells in the kidneys that produce renin, inhibiting angiotensinogen's conversion to angiotensin I. This prevents water and sodium retention and vasoconstriction, reducing blood pressure. Vasodilators such as nitrates and hydralazine primarily work by dilating the arteries and veins, which lowers the blood pressure. Alpha-adrenergic blockers, such as prazosin, act by preventing catecholamines from entering alpha-1 receptor sites in the arteriole's smooth muscle. This causes vasodilation and reduced blood pressure. Central acting agents, such as clonidine, block the signal from the brainstem that causes the release of catecholamines, which stimulate beta cells in the kidneys. This causes vasodilation and reduces the blood volume and blood pressure. For a patient with hypertension, individualize your nursing care based on her condition and prescribed treatments. But expect to perform these general nursing interventions. Check the patient's heart rate and blood pressure every 4 hours or more frequently. To obtain an accurate blood pressure reading, make sure the patient hasn't had caffeine or smoked a cigarette in the last 30 minutes. Also, help her feel relaxed. And be sure to use the correct size blood pressure cuff. A cuff that's too small will give a falsely elevated reading. In addition, be sure to insert and maintain an IV access device to administer drugs, place your patient on a cardiac monitor and be alert for life-threatening arrhythmias, and maintain your patient on a low-sodium diet. Remember to evaluate the effectiveness of the patient's diuretic therapy by measuring his fluid intake and output and checking for a negative balance. Also, monitor your patient's heart and breath sounds at least every 4 hours. Listen for resolution of abnormal heart sounds and crackles. Before your patient is discharged, meet with him and his family to review the information he needs to control hypertension at home. Be sure to reinforce instructions about drugs, including their dose, frequency, and side effects, lifestyle changes such as losing weight, following a low-sodium diet, and limiting alcohol intake, signs and symptoms to report to the physician, and follow-up care. In this program, you saw how hypertension causes vascular changes and organ damage while producing few symptoms, if any. By understanding the pathophysiology of this silent killer, you can assess your patients expertly, evaluate their treatment's effectiveness confidently, and anticipate or prevent a wide range of complications. In your practice, keep this information in mind so you can see through to the causes of hypertension and plan your care with a full understanding of its effects. For your patients with hypertension, your knowledge and expert care could put them on the road to recovery.